We'll now move to the sort of second phase of the day, which is a panel discussion. We've got three fantastic panel members, which it's a pleasure to introduce. Immediately to my left is Neha Jain. Neha's a Paediatric and Adolescent Oncology consultant at the Perth Children's Hospital and in the second year of her PhD at the University of Western Australia. Next is Andy Toner. Andy's a consultant anaesthetist at Royal Perth Hospital and a clinical trialist. And then at the end of the set of chairs is Chandra Balaratnasingam, who's a ophthalmic surgeon and ophthalmologist at the Lions Eye Institute. And you describe yourself as a mid-career researcher or still early?
Oh no, definitely mid-career.
Okay. Andy, you're mid?
I think, yes.
Okay. And Neha?
Early.
Okay. So I was hoping, just starting with you, Neha, if you could just, in 1 minute or so, give us a little bit of background about yourself, what brought you to this point in your career, and your goals.
So I'm a paediatrician, really. Started med school forever ago, wanted to be a paediatrician and a clinician at heart. Really got interested in research by default because you kind of realise that that's where impact is to be made and changes to be made and where you can really impact what's happening in the clinical world, and you get frustrated by doing the same thing that may or may not be making sense. So that's how I've ended up in research, is really driven by patients and what I see and how I can make a difference. And that's kind of where I wanted then to start leading my kind of ongoing career for the next whatever amount of years there are.
In 20 seconds, tell us about your PhD.
My PhD is on trying to harness the immune system to try and fight cancers in 20 seconds.
Less than 20 seconds, that was impressive. Andy, what's your story?
So my story as a clinician-scientist begins at undergrad medical school, actually, in the UK, where just in that first year, I remember being blown away by what we have worked out about how the human body works, the complexity, and I was just enormously grateful to the people who'd spent their lives finding out this knowledge for which we all benefit. So I was really, really inspired right from the get-go, and I knew that I wanted to be part of that as much as I could. So then I did my medical training, 6 years as a med student, and then clinical training in the UK, 7 years of anaesthetic training, and towards the end of that I stepped sideways and did a PhD, which is obviously a critical step in becoming a clinician-scientist. And then the next most important step was the decision to come to Perth in 2014. I knew a bit about Perth, and I knew it would be a fertile ground for me to express myself, both clinically and academically. Fortunately, that's happened, and so now I spend half of my time as an anaesthetist at Royal Perth Hospital, putting people to sleep for major surgery, things like taking bits of liver out, pancreas out, quite a big assault on the body. So we try and get them to recover as well as possible, and then I spend the other half of my time running clinical trials, trying to discover new interventions that can help guide the body through this assault. So that's me.
What was it about Perth or Australia that made it an attractive destination?
So I'd been out here, as many people do, in the early years for 1 year, and I just knew it was a great place to raise a family, but also it was well funded, well organised, and fundamentally I knew that someone was going to pay me to do research, whereas in the UK I was going to have to spend many years doing it pro bono, which wouldn't have got the balance right, and I think I would have stopped.
Can I ask if the ANZCA clinical trial network was a factor?
Absolutely, yes. Yeah, no, there I am as a sort of budding academic in the UK and reading lots of really bad papers, and then suddenly you see these large multi-centre trials coming out that are really changing practice, and that is absolutely, I was like, oh my, well, if they can produce that, I want to be part of that. And so just in December, I joined the executive of that infrastructure such as the fulfillment of that goal, yeah.
And Chandra, what's your story?
So my story's, it's pretty similar to Andy's. A bit later on in medical school, so I'm a local graduate from UWA, School of Medicine. Around fourth year, I was doing an ophthalmology rotation and I met Bill Morgan. He was one of the consultants at the time, and, you know, it was just quite fortuitous. We started talking about, glaucoma, and he suggested that perhaps I should get involved in a project. So this is in fourth year medicine. And I just loved it. And I think with research, you just have to like it, otherwise you won't do it. I think that's probably the key, the way I explain things to students. So I'd worked with him at the Lions Eye Institute through medical school, and I've completed training. I've completed my medical school studies, worked as a resident, but during that time I still was, peripherally involved in research, doing some work on the weekends and so forth. And then I did my PhD, so I interrupted my medical training and did 4 years of full-time lab-based research at the Lions Eye Institute. So my research at the time was looking at how the optic nerve degenerates in glaucoma, or pressure elevation in the eye. After I finished my PhD, I started ophthalmology training in Perth, and then I went overseas to Vancouver for a year and a half for a fellowship, and I went to New York City for another 2 years for a fellowship. Stayed there as a consultant for a year, but at the same time doing quite a lot of research, in Australia, but also New York and USA, and then returned to Perth. This is where I grew up. The Lions Eye Institute is so well, the infrastructure to do basic science research is all there. My mentors were there. The lab group that I had done all my research with was still, going. So it made it very easy for me to come back. So now I practice as an academic. I'm a clinician-scientist, so I try and spend 20% of my time in the lab if I can, and the rest of the time is clinical work, private and public practice.
Thanks. Now, do feel free to interject if you've got any questions or you want to contribute to the discussion. But I'll just throw it open to whichever of you wants to take this first. I'm interested in what you saw as your inspiration to be a clinician-scientist. I think some of you have alluded to that a little bit, but hoping one of you might take it a bit further. Neha?
I guess I'm quite different to the gentleman in that I'm probably entering research a bit later in my career, and what I said at the beginning has kind of is really the ability to make a difference to patients in a very live manner, a bit like the clinical trials, because that is what I love, is being the clinician and being able to do that side by side, and translating things from the bench to something that goes into a patient, I think is an amazing thing, and that's been my driver for wanting to do research and doing a PhD at this time in my career. So it is, patience, I think, in the end.
If I can also ask a question to all three of you, to what extent is your motivation driven by poor outcomes or unmet need in the patients you care for? Andy?
Yeah, I mean, that's what it's all about, really. So in my field, what we're talking about is complications after major surgery. One of the change points in my mind was a paper that came out, the big American database group that showed that if you have a complication after surgery, your risk of mortality in 30 days is increased. That's intuitive. But then your risk of dying for the following 7 years was also accelerated. So it has a huge long-term impact. So it probably leaves like a biological imprint on the body that leaves you vulnerable to chronic disease. So if you can shepherd someone through that acute phase, the benefits are enormous, potentially. So about 1 in 5 people having major surgery will have a big complication. If you can reduce that even a small amount, it's enormously useful. And of course, in my field, you've got this scaling thing where, there's 300 million substantial surgeries per year. Even a 1% improvement is a lot of people helped. So that's a big motivator.
Chandra, blindness devastates people, and you're in the business of stopping them going blind.
Yeah, absolutely. I mean, I think in this day and age, in terms of research, you really have to find the value of what you're doing. I mean, in ophthalmology, I do most of my research is on diabetic retinal diseases. You know, it's a very common cause of blindness in working age populations. There's a lot of things we don't know about how people go blind, and there's a lot we can't do actually to stop that from happening. So there's a lot of opportunity there for, research, basic science matched with clinical translational research. So, of course, you try and identify, we don't have an answer to this big problem, let's try and solve it. But I think from a practical point of view, in terms of the way the funding and grants work, if they can't see that translational benefit,
Yep.
You have to follow your passion, but at the same time, you need money to do research. So you have to be a bit wise about how you strategically pick the topics that you want to investigate. Yeah.
Now, I think you indicated that as a clinician, one of the things that had motivated you in terms of research was facing clinical decisions with uncertainty and without being guided by high quality evidence. So I'm interested for all three of you, starting with Neha. Each of you will be making clinical decisions continuously in your clinical work. What's the quality of evidence like in each of your fields that guides that decision making?
Paediatric oncology is a very, research-driven field. So we are very much so. The reason I kind of got into research is after entering paediatric oncology. So most, 98% of our children will go onto an upfront clinical trial at the time of if there is something open for their particular disease. We do with a lot of rare diseases, and so really the research decisions are complex once you get past upfront clinical trials, because there we have, unlike what the gentlemen are working on, we have a small cohort of patients with rare diseases, and so we're working in international consortiums to get the numbers up to 300, 400, 500 patients to get a source of evidence on what we're doing. Otherwise, you're working with case studies or rare reports. So it's a totally different kind of sometimes lacking field of research, despite very good attempts to try and get that information together. So it can be really complex to make those decisions, and hence the drive to get the evidence together.
Do you have good evidence for, say, first-line therapy, but not necessarily second-line therapy, and also not necessarily the sort of broader supportive treatment decisions that you make?
Yes, exactly. So first-line therapy is in the most common childhood malignancies. It's very well studied, but what do you do when they relapse is the tricky bit, and that's where I try and concentrate my research efforts, similar to what Chandra was saying, that you want to do something that makes an impact, that is researchable and translatable. So you want to find out what you can do to improve those outcomes and to make things.
Andy, do we know the constituents of the optimal anaesthetic?
Well, it's sort of anaesthesia and perioperative medicine. I think we've got very good at taking people through surgery and safely delivering them to recovery without too much nausea, too much pain, without a life-threatening event like anaphylaxis. But where we're lacking is in those long-term outcomes I alluded to, is knowing what interventions work there. And to answer your question, we're working in the dark. And I'd say we're an immature research specialty, and one of my goals is to get up to the levels of oncology and cardiology and ophthalmology. It's very rare.
You've got a global sample size of 300 million.
Yes, I know. And the amazing thing about major surgery is the timing of the injury. So if you're an intensivist, you have to deal with a lot of sepsis. The boat has sailed a lot of the time by the time you get to the patient. We know when it's happening. So the opportunities are great, but we don't have a lot of evidence to guide us. And the way things work is, trends emerge. Someone comes up with an idea. So at the moment, there's a lot of interest in, exercising people before major surgery. Sounds intuitive. Then you'll get a group really enthusiastically doing it. and then you might get some small trials with bias saying it works. And our job is usually to come in, do the big trial, and unfortunately say it doesn't work.
Chandra, when you're in the clinic, I think you said 80% of the time, can you call upon high-quality evidence to guide your decision-making?
Look, I think ophthalmology is pretty good. I think we have, quite a number of good clinical trials to guide most treatments. And also remember, Neha and Andy, when they are dealing with these situations, it's sort of a life and death scenario. For ophthalmology, it's not usually. It's more, we have more time, and a lot of our management is conservative. But that all being said, there are a lot of common conditions like age-related macular degeneration, diabetes. We don't actually know what causes it. Well, we know what causes diabetes, but we don't know how the vision loss occurs in terms of the pathways. So there's a lot of stuff we don't know. And, I'm, as a retina specialist, I deal mostly with people with retinal diseases. I see lots of people with dry macular degeneration, and you just can't do anything for them. I mean, you can put them on supplements to reduce the progression of their disease, but they're obviously very frustrated. They can't drive. There's no treatment per se to reverse the problem or to stop it from happening in the first place. So our frustrations are a little bit different to what Andy and Neha are describing in their work.
So you guys are passionate, enthusiastic, at different stages of journey. I'm interested to hear a bit more about some of the challenges that you've faced along the way and how you've responded to those challenges.
Sure. I mean, I think, time is going to always be the biggest thing. And if you don't have the passion, then you won't make time for it. It's as simple as that. Yeah. And to get to this stage, I think for the three of us to continue research and still have a clinical engagement, you really do want to be doing research. Balancing time with, clinic work, family, research is always going to be difficult. I can't say I've worked it out completely. And I always get it wrong. And usually I'm here on the weekends making up for it, much to the, detriment of my family, and my wife's not happy. So, you kind of have to learn to deal with those things and manage those things. Yeah, it's time is the hardest thing for me. Yeah.
Are there particular points in the journey where you feel as though you had choices and you made a good or a bad decision?
Look, I think the last talk, which sort of went through the journey, was really I thought it was an excellent talk, actually. I think we can all relate to that. I don't regret anything I've done. Obviously I was presented with certain choices throughout my career, which I didn't accept. But on reflection, I'm really pleased with where I've ended up, and I'm really proud of my career, and I enjoy what I do, most importantly.
Neha, you're at an earlier stage, but there must have been challenges that you've faced, and time has already been taken off the menu.
Time is, I think, Chandra says exactly right. Balance is a tricky place. I think the other thing that you're always wondering, particularly, I think, as a female, is when do you balance all of those bits? And there is if you want a family, then you've got time that you have to take away to have a family, and how do you balance all those parts? So they're challenges that are inherent to what you do, and I think knowing what you want to do is not always easy. So that's the other thing. There is a bit of a discovery process to it. I didn't want to be a clinician researcher when I was a medical student, or even when I was going through my internship or early years. I didn't really think research was for me, but it's something that I've kind of discovered about myself and what I want to achieve. So I think those things kind of also, you have to be open to things that come in front of you, but recognizing that you can change paths when and if you wish, with all the constraints that are then part of that. Yeah.
I often tell people that we've got long careers now.
Yes.
And there is an opportunity to take advantage of that.
Exactly.
Andy, we've had time, family.
They're sort of all interconnected, aren't they? But
how about money?
yeah, I was going to talk about money. I think the timing of your higher research degree is the key thing for me, ideally a PhD. And just don't leave it too late, I guess, is the best advice I could give you. If you're sitting there in the audience and think this is for me, then you need to be courageous and do it early. So yeah, when I came to do my PhD, finances was a huge part of it. I got used to a training doctor salary in the UK, which was reasonable, nothing but Perth standards. And my first choice PhD was to look at the neuroscience of consciousness in a lab in London. And I'd have had to take a third of my salary for 4 years to do that. And I thought long and hard about it, and I thought it's too risky, I can't do it. So I was flexible, and things like it worked out well, and I don't regret anything, and there were opportunities earlier in the path to choose an academic pathway, and I was a little bit not courageous enough, and I wanted to get my clinical work to a level that I was confident. And I look back and go, well, I could have taken that opportunity, I should have been bolder, perhaps. So if you know, do it early. That's not to say you can't do it at a later phase effectively.
I would
Guys.
say, yeah, same in the sense that exactly what you're saying is that if you know, then I think do it at the time that you know and it feels right for you, because it's absolutely tricky to do it at this time in my career. It's to do a PhD when you're taking a huge salary cut and you're compromising the other parts of your career that you want to take forward. So the moment that you know you want to do something, you should grab the opportunities that are available to do it.
I want to ask you a slightly left field question. It's inevitable that you've had some failure along the way. So I'd just like you to comment on not necessarily the details of the failure, but how you responded to it and how it changed your direction.
No, it's absolutely inherent to what we do and our lives, and it doesn't end.
Yeah.
And the response is the key thing.
I had an unsuccessful NHMRC grant yesterday.
There you go. And, you know, if you're cut out for this game, it just drives you on. Right, I'm proven wrong. I'm going to get it better next time. And you know there's politics. So you just accept that. So I had lots of unsuccessful applications when I was trying to get into an academic life, because I wasn't known by the key players around London. But I kept going and, you know, eventually made it happen. So failure is a very important part of the process. You just embrace it and get it to drive you forwards.
I totally agree with everything Andy has just said. I think you have to be prepared for multiple failures every year if you're doing any level of decent research. You know, I think the two main points where you will fail is you'll get a paper rejected or you won't get the grant. One is a bit more devastating than the other, but you know, I mean, it is a blow to the ego, but you just have to learn to move past it. Easier said than done, but you won't survive research if you can't handle failures.
You get a lot of experience. You get a lot of practice.
But you just don't get used to it. You know, it's still bad each time you miss out on the grant or the paper gets rejected, but it is what it is.
And in a very day-to-day, you know, in the lab, there are research kind of failures every day. So you do something and then you get to the end of your week or 2 weeks and you say, well, that was 2 weeks wasted. So that happens to me at the moment all the time. So I think, yes, you have to be able to. And one of the things I think that you have to like about research is trying to troubleshoot. What was it that made the paper not get accepted? What was it that made that experiment fail? And if you're okay doing that troubleshooting, then you're going to be okay doing research.
So what makes up for all of that failure?
When you get it right.
I think for me, it's like the ability to be creative, partly. Yeah. Clinical work is fantastic. You get this really direct feedback that you've been useful. You go home at the end of the day, go, you know what you've done that day. Research can be dry at times, very abstract, but there are moments when it's really creative. You feel you're bringing ideas together that people I haven't had before, certainly haven't expressed in the literature. And there's a potency to that it could really help people, and that's a pretty good combination.
Is discovery important?
Absolutely, yeah. I mean, that goes back to what I said at the beginning. You know, we all benefit enormously from these discoveries.
Can I ask each of you to share an example of your research that has had impact or improved patient lives, or at least on the way to improving patient lives? Chandra?
So a lot of the work we do is basic science research on diabetic retinopathy. So one of the main causes of sort of severe vision loss in diabetes is what's called the retinal ischemia or macular ischemia, where the capillary system just shuts down. So we don't have a treatment for that. So at the moment, we are looking at this transcriptomics expression in the retina in diabetic eyes with ischemia and non-ischemia. And we're actually working with Roche, the pharmaceutical company, to try and find a new target, an antibody or a new molecule that we can use to stop that from happening. So that, to me, is very exciting research. And that's really, on the backbone of probably 5 to 6 years of basic science research development to get to that point, and to put a proposal to a big pharmaceutical company like Roche. So if we get success with that project, I think, we're literally impacting the lives of millions and millions of people around the world. So I think that has major translational benefits. So, that's something, and that you sort of mentioned discovery as being what gives us the buzz. So 100%, I think that's the number one thing. You find something new and it's exciting, and that's sort of, you forget about all the failures you've had with the projections and the grants. So that's what you need. You need a few wins to keep you motivated.
I worked as part of my time at Great Ormond Street in the clinical trial on CAR T therapy in solid malignancies, and that was, similar to that whole discovery, translational. It didn't work, but it was amazing to be part of something that you were trying for the first time in paediatric children to cure or attempt to cure it, what's essentially incurable disease. And it's a very kind of real impact that you're having, even if it grants patients a couple of months of extra good quality of life. So that's kind of where I want to be, and hence kind of has prompted the rest of my kind of research decisions and what I want to be doing. So it's that trying to find something that will work.
Andy?
Yeah, well, I hope the best is still to come. And we from idea to phase 3 trial reliable evidence is pretty much 10 years in our field. And unless you're really, really successful, you don't run them too much in parallel, so you don't explore that many ideas. But in terms of what we have done over the last 10 years, and this was work led by one of my current mentors, Thomas Corcoran at Royal Perth Hospital, but I've made important contributions, I hope, is around whether we should routinely give a steroid to people having decent-sized surgery. And 10 years ago, there was about a 50-50 split. Half of anaesthetists would routinely give it because it reduces nausea and reduces pain and enhances recovery to some degree. And half of anaesthetists would steer away from it because they were concerned about suppressing the immune system at a critical time when you need to heal and you run reports of infection. So we did some work, systematic reviews, meta-analyses, building up to a very large phase 3 trial, which has shown definitively that there is no risk of increased infection. And so that is in things like UpToDate, which many of you will have used as a tool for evidence-based medicine at the bedside. And now I would say the vast majority of anaesthetists routinely give the stuff. So and it comes back to the scaling issue that's happening all over the world. So it's a benefit.
Can you tell me a little bit about some of the mentorship relationships or the value of mentorship that you've had along the way?
Mentors, I think, are a critical part because they help support you through those ups and downs, and really those bits, somebody to look towards to guide you. Am I making the right decisions? I must say my mentors have changed because I've moved around quite a lot, and so I find having somebody in the same location quite important, but that may not necessarily have to be the case for everybody. But I do think mentors are an important part, and people that you can relate to, so their journey. So for me, having particularly a female mentor was important because I need to know that you can balance family and a career and research all at once. It's slightly different when you are a female and you are potentially the primary carer for those children. So you want to be able to see somebody who's done all of it ahead of you. So mentors, I think, are key to get you through medicine in general and clinician researcher. Yeah.
Was finding a mentor a passive or an active process?
I've been lucky, I guess, in that I've encountered people that I've been able to look forward to and have the discussions with, and therefore kind of use as mentors throughout. So it has been probably passive on my end to find the right people or bump into the right people at the right times. So I haven't actively gone looking, but I do think it's important. So I would say people should actively be looking if there was something to change. If I didn't find the right people, then I think I'd go actively looking.
Chandra, you first met Bill Morgan as a fourth-year medical student. I'm presuming that was a little while ago.
Yeah, that was a while ago.
Bill's still a mentor, is he?
He is, yeah. So I think I've been very lucky. And probably my story is a bit atypical because, we still, work in the same lab. And Dayi, who was my main PhD supervisor, I won't tell you how old he is, but we still work. So the three of us, for 25 years have been working together, and the dynamics of the relationship are still pretty similar to when I was a medical student, actually. But
they still treat you like a medical student?
Well, I think as a mentor, of course, their principal role is to guide you through the research and to teach you things. But I think an important part of a good mentor or a supervisor is their philosophy on why they're doing research and how they approach it, how they approach, failures when they don't get grants and how they mitigate those sorts of things. You learn all of those things passively over the years. They're not sitting over you and directly telling you, well, if you don't get this grant, this is what you do next. It's a lot of observation and relationship building over the years. So, I can't complain. I've been very lucky.
Yeah, I think when I was this kind of like luck is a word that came up a lot. Things that when I was saying, in whatever walk of life, if you're successful, if you don't acknowledge luck, then you're not on the right path. But yeah, two really important mentors for me. My PhD supervisor, goes without saying, and I found Gareth Ackland online. He's now editor of the British Journal of Anaesthesia, or one of the editors. So I sought him out after a number of failures of applying for things, and he gave me my first break. And he's really kind of subversive, workaholic, some would say psychopath, but he expected a lot of his PhD students, but he gave a lot back. And as a consequence, he gave me the confidence to think differently, and also get some good publication support momentum. So that is an absolutely key relationship. And you can be a great candidate, get the wrong supervisor, and things aren't going to work out so well. And then it's sort of the postdoc years, you probably do need a mentor who's very influential that goes into bat for you. So for me, that's Tom Corcoran at Royal Perth, who is just an incredibly energetic and collaborative individual, who has opened so many doors for me. And research is a battle of ideas. Ideas are cheap. People are always, throwing out ideas. But who do you take seriously in that amongst that noise? So you need people to say, perhaps you should take this person seriously. But that's the value of mentorship.
An important thing I learned at a Academy mentorship day was the difference between mentorship and sponsorship, which is about they can be one and the same person, but sometimes you've got people who are creating opportunities for you, which is different to mentorship, and sometimes people who've created opportunities for me haven't been mentors. I just wanted each of you to think personally, what advice would you give these guys? Knowing what you know now?
I think take opportunities when they come and be open to ideas. Your career, as you see it, wherever you might be in it, it may not be where you end up, and you just need to be open to that you might be interested in something different to what you think you're interested in. That's probably my biggest take-home message from how things have changed.
If I can just add to that, I think that's such good advice. Equip yourself with skills so that you can be flexible and take advantage of opportunity as they come your way. Andy?
Yeah, I think just come back to that main point of do your PhD early if you can. Yeah, so if the passion burns brightly, then just go for it. We talk about luck, but you do make your own luck, of course. Work hard and take the opportunities. Yeah.
Luck is incredibly important, but it's also the case that, and this is a quote from someone, that luck favours the prepared.
I know you have already spoken to this a little bit, but as people involved in medicine, I think we tend to be very religiously attached to our routines. So how do you, I know you've already talked about this, but how do you deal with the sudden break or interruption to your routine, something you worked on for 2 weeks suddenly doesn't work, and now you have to go back to the drawing board? So how do you sort of make peace with that, I guess is my question.
I think research is really good at teaching you how to make peace with not getting things right and then still. So one of the things I love, what I've loved over the last year, is actually trying to do that thinking around what do you do next that actually works. And I think one of the things that I really find exciting about research is the fact that you have to problem solve and you have to think. What's great about clinical medicine is that you see patients, you generally know what you're going to do, you have the same conversation that you've had lots of times, hopefully, by the time you're doing it as a senior, and you kind of already know well before you get into that room what that particular conversation is going to be like. Of course, there are differences between patients, but there is a gist for where you're taking it, whereas research, you don't know what you're going to get into and what you're going to get, and that's, to me, a great balance between the two, is not knowing and knowing with some level of certainty what that day will look like.
This has been said to me before. Do you think genetics is the next frontier in terms of research in medicine? And someone who's not very familiar with genetics, it feels like a very big learning curve for me. So how do you deal with being the first to do something and having no idea how to do it?
I don't know the answer to that question, but I like to think from time to time about doctors 300 or 400 years ago who we look back at and say they had no idea what they were doing at the time, and I don't know if they thought that they were at the cutting edge at the time. We kind of feel like we're at the cutting edge now, but I'd love to know what the doctors in 300 or 400 years are going to think of us.
Just to add to that, I think we're actually quite a golden age of research in areas like cancer and immunotherapy and heart disease, and there are new biological agents being focused.
Gene editing, gene replacement.
Exactly. And I look back when I was a med student and the Human Genome Project was going on, and it's one of those blue sky things, and I think we're reaping the benefits of that deep understanding of cell pathways. So probably yes, epigenetics, how genes are turned on and off, rather than the code you're born with.
But I think it's part of the discovery. Again, you're not a master of anything when you step into anything at any point in your life. So I think always be a bit cautious about being awed by it. I've always felt that I kind of felt, they are too far in their career, they already know too much, and therefore I cannot be that person. So you'll learn, you're capable, you'll go through the process and you'll do exactly the same as what the other person before you has done. So whatever it is, you'll learn it because you can.
And Chandra, to close, your bit of advice?
I don't think I have anything extra to add. I think everything, the important stuff's been discussed, and I think, I just keep coming back to the same point. I think if you're passionate about it, you'll see it through to the end, irrespective of how many failures you're going to have. And if you were a junior researcher, like a medical student or something, my advice would be to, if you commit to the project, make sure you stay there and finish it. There's nothing worse than showing, interest initially and then nowhere to be found. It's really disappointing when that sort of behaviour happens. But, if you're passionate, you'll stick through it.
So the advice is think big, have fun and make things happen.
Yeah.
But Chandra, Andy, Neha, thank you very, very much for sharing the insights with us today.